An internal thoracic or internal mammary artery composite graft, most commonly a Y graft or T graft, is an advanced surgical configuration where a secondary conduit is attached directly to the internal thoracic artery rather than the aorta, usually in aortocoronary bypass grafts, ACB of SVG, saphenous vein grafts. Proximal end is anastomosed directly to the aorta. The new approach is the cornerstone of aorta no-touch surgery, designed to reduce the risk of stroke by avoiding manipulation of a potentially calcified ascending aorta. In a composite setup, the left internal thoracic artery remains attached to its origin, that is the subclavian artery, and is typically grafted to the left anterior descending coronary artery. A second conduit is then anastomosed to the side of the left internal thoracic artery. T graft or Y graft, a secondary conduit, usually the right radial artery or a saphenous vein graft, is joined to the leta in a T or Y shape. This configuration is frequently used to achieve total arterial revascularization, providing the entire heart with arterial blood flow using only two inflow points, left internal thoracic artery and right internal thoracic artery. Internal thoracic artery is not just a tube, it is a living conduit with unique biological properties that benefit the attached composite segment. Internal thoracic artery provides high levels of nitric oxide which diffuses into the attached composite graft, promoting vasodilatation and inhibiting intimal hyperplasia in the secondary segment. The ITA is highly responsive to the metabolic demands of the myocardium, increasing its diameter and flow velocity as needed, that is, flow autoregulation. By eliminating the need for a proximal anastomosis on the aorta, surgeons significantly reduce the risk of embolizing atherosclerotic debris, which is a primary cause of perioperative stroke, that is, aortic sparing or aorta non-touch method. The primary challenge with composite grafts is the reliance on a single inflow, that is the left internal thoracic artery, to supply multiple coronary territories. For a composite graft to function well, the target native vessels must have high-grade stenosis, usually more than 70 to 90%. If the native vessel has only moderate stenosis, native blood flow may compete with the graft. Because the composite graft is a long, high-resistance circuit, the native flow can win, leading to the string sign, narrowing atrophy, or early occlusion of the composite limb. Long-term data suggests that composite grafts are highly durable provided they are constructed with arterial grafts. Leta-Reta Y graft. 10-year patency for Reta used as a composite graft is significantly higher than when SVGs are used. Leta-Radial Y graft. Large-scale studies show that radial artery performs better as a composite graft from the leta than as a direct graft from the aorta, likely due to the protective hormonal environment of the internal thoracic artery. An SVG ITA composite graft is a specific surgical configuration where a saphenous vein graft is attached to the side of an internal thoracic artery rather than being connected directly to the aorta. While total arterial revascularization using only arteries is often preferred, using a vein as part of a composite graft is a strategic alternative when arterial conduits are limited or patient anatomy dictates a more flexible approach. In this setup, the left internal thoracic artery is harvested and grafted to the left anterior descending coronary artery as usual. The saphenous vein graft is then piggybacked onto the leta. The vein is sewn into the side of the leta, forming a Y or T junction. The other end of the vein is grafted to a secondary target such as a circumflex or right coronary artery branches. Using the internal thoracic artery as the source for the vein graft offers several physiological and surgical benefits. The internal thoracic artery is a highly bioactive vessel that produces nitric oxide. When an SVG is attached to it, the vein is exposed to this vasodilator-rich environment, which may help prevent the vein from developing early atherosclerosis. By avoiding the aorta entirely, the surgeon eliminates the need to clamp or manipulate the aorta. This drastically reduces the risk of dislodging plaque that could lead to a perioperative stroke. The internal thoracic artery provides a more physiological pressure wave than the direct high-pressure pulsatile flow of the aorta, which may reduce the mechanical stress on the vein wall. Performance of a vein in a composite setup differs slightly from a traditional aortocoronary vein graft. Like all SVGs, the risk of intimal hyperplasia remains. However, because the SVG is attached to an artery, that is the leta, it undergoes arterialization more smoothly. The primary risk is that of the leta must provide enough blood flow for 2 or more coronary territories. If the left internal thoracic artery diameter is too small, it may not be able to meet the demand during peak exercise, leading to flow reserve issues. Some studies suggest that SVG ITA composite grafts have superior patency compared to traditional aorta SVG grafts, likely due to the protective endothelial factors provided by the internal thoracic artery. Here is a comparison. Inflow source for aortocoronary SVG graft is ascending aorta, while for SVG ITA composite graft it is the internal thoracic artery. Stroke risk is higher for aorta SVG graft because of aortic manipulation, while for SVG ITA composite graft it is lower as it is aorta no touch. Bioactivity is minimal for aorta SVG graft, while high nitric oxide from internal thoracic artery is there for SVG ITA composite graft. Surgical complexity is standard for aorta SVG graft, while it requires high precision Y junction for SVG ITA composite graft. Ideal use aorta SVG graft for diffuse disease large targets and SVG ITA for calcified aorta limited conduits.